Dr. Mazhar, how many students total?
So far, it is only 18 students.
No, but
I think you can start the lecture. If any students come, I will let him or her in.
No problem. Total, how many lectures in this session? Otherwise, in your this block?
2. This is radiology 1. There is one more, that is radiology 2.
No, total number of students registered in this module. How many students, boys and girls?
60, I guess. 60.
So out of 60, almost 1/3 are present.
Yeah.
Okay, fine. So with your permission, I start, Dr. Mazhar. Assalamu alaikum. Students, how are you?
Alaikum assalam.
I welcome all of you. I have honored to present you 2 radiology lectures, one today and second one will be in the start of December. Most likely the date is 10th of December, Thursday, 10th of December. Okay, just let me know one thing. I have 2 lectures. One is related to the abdomen imaging, and second is related to the pediatrics and gynecological problems and related imaging. So currently what you are learning in this block, is it relevant to the abdomen or relevant to the gynecology and pediatrics? So I can present accordingly first lecture. Oh, okay, divided into 2. So, okay, so I will start with the first lecture about the abdominal imaging. Okay, let's present now. Share screen. Is it visible? The lecture is visible?
Yes.
Okay, fine. Okay. Bismillahirrahmanirrahim. I welcome all of you. And in this session, today's session, our objectives are to, first of all, recall the basic core anatomy which are relevant to the X-rays, plain X-rays, radiographs, and some of the contrast studies, barium studies, and high-tech modality, that is the CT scan. So first of all, we will just identify the important landmarks of the anatomical structures, and then in the second step, we will try to learn some of the topics, medicine-related topics, which were given to me, which are relevant to your courses, like gastroesophageal reflux disease and the other lower GI bleeding, irritable bowel disease, and so on. We will go through these topics. The session is sort of a more interactive, and you are allowed to ask me anything, interrupt me during the lecture. Feel free, because this is your session. The sole objective is to clarify your sort of difficulties and the understanding on the imaging, how things are looking, because you are less exposed to the radiology and imaging part. So don't feel even to ask the small things, minor things. If you don't know, no problem. Don't hesitate. Uh, we can learn by our mistakes. We can learn by interrogations. So feel free to ask me anything. Okay, let's start with the first slide regarding the abdominal X-rays. Various terminologies are used in the medicine book: radiographs, plain X-rays, X-rays, abdominal X-rays. So these are the different terminologies, terms used for the simple X-rays relevant to the scanning of the abdomen. So what could be the indications, applications, uses of such X-rays relevant to the gastrointestinal tract? There are certain positions in which we ask the patient to occupy that position, and then the technologist takes the X-rays. So commonly relevant to the abdomen, the supine position, supine abdominal X-ray and the erect abdominal X-ray are taken, and these are the primary initial investigations for majority of the uh, questionable clinical symptoms relevant to the abdomen. So when a patient lies in a supine position, means his back is on the table and front is facing the X-ray source. X-rays are passed from the front of the abdomen in lying position and covering the lower part of the chest, including the diaphragm up to the pubic symphysis. So the whole abdomen and pelvis region, the X-rays would pass. And according to the, I'm just giving you a background how X-rays are working, how X-rays are produced, and they are producing an image on the X-ray film or on the monitor. So when the X-rays are passed, the air containing structures like the lungs, like the intestine, they through which the X-rays can easily pass. And then on the back side, in the older days, there were the films which were developed, processed, and developed in the dark room. But nowadays, it's connected to the digital system. So there is a system which can convert the attenuated X-rays into the black and white image on the monitor. So as a result, as X-rays are passing easily through the air-containing structures, including the air in the intestinal tract, they will cast a lucent shadow, a black shadow on the X-ray. The objects in the body which have high, like metallic objects, high atomic number, like calcium-containing structures, the iron, metallic rods, for example, any metallic foreign bodies, they mostly obstruct the passage of the X-rays to pass through it. As a result, they produce an opaque shadow on the X-ray image. So they are visible as a white shadow. In between, we call it a soft tissue shadow. This is a great list of items like skin, subcutaneous tissues, soft tissues, muscles, blood vessels, nerves, viscera wall, any fluid containing structure, fluid in the GI tract, small intestine, urinary bladder, gallbladder, sort of. They all produce a soft tissue shadow, which appears like a gray white. So these are the three basic shadows we appreciate on the X-rays. So is the concept of the X-ray production and the shadow appearance on the X-rays clear to you?
Yes, doctor.
Yes.
Okay, fine. Second step. So regarding the abdominal X-ray, so when patient is lying down and X-rays are taken. X-rays pass from anterior aspect and coming out from posterior. This is called a supine abdominal X-ray. The second position is the in erect position. The X-rays are passed from anterior aspect and on the posterior aspect. X-rays are collected on an image, and then image is processed in the computer system. That would be called an erect abdominal X-ray film. Okay, what are the indications of the supine abdominal X-ray? Usually, we check the lumen, the air containing lumen of the intestinal loops, small intestine and large intestine, how they are appearing, and how much they are they measure. We can measure by the system or by the calipers given on the system, or even on the heart film we can measure by the scale. So based on that, we can decide it's a normal intestinal loop, normal diameter, or they're dilated. So dilated intestinal loop is one of the sign for intestinal obstruction, a mechanical obstruction, a paralytic alias physiological obstruction, or enormously dilated colon, toxic megacolon, or a twisted colon, that is the volvulus, sigmoid, or cecal sometimes. Okay, and occasionally air can come. Normally, there is no air in the wall of the intestine, but if there is a necrosis of the wall with necrotizing enterocolitis, for example, or ischemic necrosis, so air can come in the wall of the intestine, which is called pneumatosis intestinalis. Okay, air can come in the biliary passages, in the portal tract, in the portal veins, as well as similarly the high density material like the calcium containing stones, gallstones. Okay, although most gallstones are not radio opaque because they are cholesterol and pigment containing stones, but almost 30% are containing calcium, so they can be visualized by the abdominal X-ray. Rarely, a complication of a chronic cholecystitis, there's a calcification in the wall of the intestine called a porcelain gallbladder, can also be detected by the abdominal X-ray. Similarly, in chronic pancreatitis, sometimes there are multiple stones, calculi, calcifications in the pancreatic duct, which can be visualized by the abdominal X-ray in the epigastric region. So these are the few indications or conditions which can make easy diagnosis by the supine film on abdominal X-ray. Erect abdominal X-ray film is an additional view, is an supplementary view, particularly relevant to the intestinal obstruction. That in the erect posture, we can see multiple large air fluid levels related to the intestinal obstruction. So that was the first relevant condition. And second, we can see the collection of an abnormal air under the domes of diaphragm if we ask and make the position of the patient to remain erect for 10 minutes, so that the air in the peritoneum, which has accidentally come due to trauma, due to rupture of the intestinal wall, due to rupture of a peptic ulcer disease in the duodenum or stomach. So air can collect under the domes of the diaphragm, and that condition is called pneumoperitoneum. However, the erect chest X-ray is more sensitive than an erect abdominal X-ray because the rays are more horizontal, better outlining the diaphragm and air under the diaphragm. So a pneumoperitoneum is better diagnosed by an erect chest X-ray rather than an erect abdominal X-ray film. So is this slide clear to everybody? If you have any difficulty or any question in your mind, please ask me. Okay. Okay, on the left side, I have shown you a typical abdominal X-ray film. Okay, from the upper abdomen up to the lower region of the pelvis, almost to the pubic symphysis. You can appreciate the gas shadows in the epigastric region, stomach gas shadows. On the left side of that, you can see the gas shadows with rostral pattern peripherally for the descending colon. And on the right side, you can see the ascending colon shadows, some shadows of the transverse colon, some central shadows of the gas in the small intestine. First of all, you should make sure you can appreciate the right and left side. If you see the top corner of your right side and the film left side, there's a L written. Can you appreciate that white color L? That's indicating the left side. Do you appreciate? Please reply me.
Yes.
So you see now, your right is patient left and your left is patient right. Is this concept clear? So you just imagine that on the x-rays, you are seeing the x-rays just like a patient is facing to you. So when a patient is facing to us, then our right is a patient left and our left is patient right. Okay, clear that one? Okay. Okay, second concept here, that this is an absolutely normal abdominal X-ray showing gaseous shadows within the stomach and intestinal loops. You should realize that the gas shadows is very much variable from patient to patient and even in the same patient from time to time. Okay, but one thing is important, that the diameter of the small intestine should be less than 3 centimeter, which is a criteria, a cutoff for to make it a normal versus abnormal. In the right side of the film, you can see there are much dilated loops of intestinal of the small intestine located mostly centrally and having a complete folds of valvulae conimentes, and by measurement on the computer in the system by scale they are more than 3 centimeter. So that gives a diagnosis that these loops of small bowel loops are dilated, and the common cause of the dilatation is a obstruction, mechanical obstruction. Sometimes it could be a paralytic ileus, which is common to see after operation when there is a cessation of the peristaltic movements. So, is this concept of the normal versus abnormal small bowel loops clear to you? And this is one of the feature for the diagnosis of the small intestinal obstruction. Clear to you?
Yes, clear, doctor.
Okay, now in this slide on the left side, there is a gaseous shadow outlining the cecum, ascending colon, hepatic flexure of colon, transverse colon, the splenic flexure of colon, descending colon, sigmoid colon, and part of rectum. They are incomplete folds in the colon called haustral pattern. So differentiation, this is a normal large bowel loop, normal colon, diameter should be less than 6 centimeter. If they are more than 6 centimeter, like in the right side film, you can see a hugely dilated colon. So that's a case of a large intestinal loops dilatation, most likely due to large bowel obstruction. So the measurements are different, 3 in the small intestine and 6 in the large intestine. Second question, second concept, how we differentiate the small intestine versus large intestine. The anatomically small intestine are centrally located and they have got more lengthy appearance, more in length, and they have got a complete bands called valvulae conjunctives, while the large intestine are peripherally located like a picture frame, and their diameter are larger, okay, compared to the small intestine, but their total length is shorter than the small intestinal loops. Is this clear to everybody?
Yes.
Okay, fine. So Fine. Okay, I will go to the next slide. That's a differentiation I'm highlighting here, the same, which I have already mentioned. Okay. Next. Okay. Stomach shadow. Okay, normal stomach shadow. If you see the chest X-ray on the right side, on the left side image, okay, right side image, the chest X-ray, the chest X-ray is showing to you below the left diaphragm. Below the left diaphragm, is there an option of marker use here? There is a use of pen. Okay, I can use that pen. Okay, this is the stomach gas shadow. Do you saw the use of pen? Is it visible to you? I'm using the pen.
Yes, it is.
Okay. Is there any option of pointer use here? Actually, mostly I'm using through the Zoom or the Blackboard. So through the Google, I'm using first time. Anyhow.
I
Anyhow.
think you can.
Okay. So this is the constant. Almost 100% should be present a variable amount of a stomach gas shadow below the left diaphragm. We know anatomically, I'm sorry, the stomach is lying left side of the upper abdomen. Uh, Below the left diaphragm should be a visible a gas shadow, a air fluid shadow, a variable amount of shadow, but must be present to indicate that this is a normal location of the air of the fundal gas shadow. Sometimes, occasionally, abnormally, as a variation, you can have on the right side, absent on the left side, means you start thinking of situs inversus or the collection, a crescentic shape collection of air below the diaphragm, commonly right, sometimes left, due to pneumoperitoneum. Clear now? Okay. Can we see air fluid levels? How much air fluid levels are normal? Normally, 2 to 3 small air fluid levels may be seen as a normal shadow in the small intestine. That's all. So it means that normally in erect abdominal X-ray film, there are not too much air fluid levels. If there are multiple air fluid levels, okay, if there are multiple air fluid levels, like in this situation, can you appreciate that above is air, below is fluid. Fluid is seen as a gray structure. We cannot see the fluid, but gas above as a lucent structures we can see. So can you appreciate these multiple air fluid levels? Okay, stomach fluid level, small intestine fluid levels. So visualization of the large multiple air fluid levels, more than 3, in the central position in an erect abdominal X-ray is an sign of the intestinal obstruction. Clear to everybody? That's a medicine books use the word step ladder pattern of the multiple air fluid levels. Okay, they are like a step ladders, no problem. Okay, so things are clear on the abdominal X-ray so far. I have just given some basic information in relevant intestinal obstruction, which is related to your this block. Okay. Second thing is related with the GI contrast studies. Okay, the contrast studies. What we do here, as I mentioned, that the things are not visualized mostly in the stomach. In the abdominal X-ray, only the lucent things are visualized. So we are dependent in the abdomen on the presence of the presence of the air. If the air is present, it's a dilated. We are making the diagnosis, but most of the things are not relevant with the air. We want to see the inside, what is happening. So the radiologists, the technologies, they devise a system that they deliberately use uh, some chemicals which have high metal content, like barium. Barium is a metal. So barium powder mixed in a water in a flavored shape, and then ask the patient to drink that flavored um, contrast. And then when it is flowing through the small intestine, sorry, when it's flowing through the esophagus, so that technique is called barium swallow. Barium is swallowed. The swallow goes to the esophagus, and the commonest problem in the esophagus is dysphagia due to stricture. So, barium swallow is an radiological investigation, is a contrast study done in X-ray fluoroscopy technique in which the patient in a standing position swallows. Patient is asked to swallow the barium, and barium is passing through the esophagus, and it is visualized. Any stricture, if present, it is visualized. Then, second investigation is the barium meal examination. When we take the meal goes to the stomach and duodenum. So, to diagnose a peptic ulcer disease or any gastric masses or gastric outlet obstruction, barium swallow is a good alternative investigation to endoscopy examination. Endoscopy examination remains the gold standard, remains the preferred investigation to see inside the lumen of the stomach and upper part of the small intestine, directly visualize the ulcers, directly visualize the masses, can take advantage, can take the biopsy of that advantage if they want to do some intervention like sclerotherapy or stopping the bleeding, like in esophageal varices and so on. Then third investigation is the barium follow through. The meals we take follows into the small intestine. So any small intestine pathologies, okay, will be can be sorted out by the barium follow-through examination, or alternatively small bowel enema, also known as enteroclysis, in which a tube is passed beyond the ligament of Treats and reaching to the upper jejunum. The saline and fluids are passed, which can be visualized, which can distend the small intestine and visualized. Okay, it's just like a barium flu, but better than the barium follow-through examination. And lastly, barium enema. We are giving enema through the rectum to outline the large intestine pathologies. Any question related to GI contrast studies? If you have any doubt, any question in your mind, please ask me.
Can you please clarify again the difference between these three barium and small bowel enema and barium enema examination? Because I didn't get it.
Okay, I will. The barium enema examination is primarily designed to outline the rectum and the colon. So a tube is passed, or a Foley's catheter is passed and returned into the rectum, and then the barium is passed by injection, okay, to follow into the rectum, sigmoid colon, descending colon, and a small amount after passing the small amount of barium. Then we make various positions, as well as we inject the air, as well as to distend the colon, as well as coat the barium on the colonic wall. So that's called a double contrast barium enema examination. And then in various positions, we try to outline the whole colon, the contrast reaching up to the cecum, or preferably reflecting into the terminal ileum. That examination is called barium enema examination. There is a small bowel enema examination or enteroclysis. The barium enema was a retrograde examination, and the small bowel enema is an antegrade examination through the mouth or through the nasal cavity. The tube is passed, which follows the esophagus, duodenum, stomach, duodenum, crossing the fourth part of the duodenum, okay, junction, reaching the jejunum, and then contrast is injected, which follows and distends the jejunal loops and ileal loops. So that visualization of the small bowel loops is called small bowel enema or enteroclysis, designed to outline the pathologies in the small intestine. Small bowel enema is considered to be more um, more controlled examination. You can stop, you can see everything. Compared to barium follow through, you are dependent on the natural peristalsis. Just patient swallow the barium, and now you wait, it is passing and following into the different parts of the small intestine till it reaches the ileum. It might take half hour, it might take 2 hour, depends all from patient to patient. So it's not a controlled examination, and it's an inferior because it's not distending the intestinal loops. I hope that things are concepts are clear to you now.
Yes, it is clear now. Thank you.
Fine. Okay, so that's a barium solo examination. Okay, the barium solo examination, and you can see that this patient is drinking the barium standing position in the fluoroscopy room, and barium is following in the lateral view x-ray. That barium is following the esophagus. There are some impressions due to aortic knuckle or the left atrium or left bronchus, okay, and sort of some double contrast esophagogram. You see some air is also distending and barium is coating the walls of that, and we can see in the AP view in the lower part of the esophagus, and that crossing the duodenum, and that's the abdominal esophagus continuing into the fundal gas shadows. Okay, so that's a esophagogram or barium solo examination. Some films are shown to you, and it's an oral examination taken orally, and images are taken, okay, in different positions, in the standing position, from front, from lateral, from oblique, whatever you need, sometimes in semi-recumbent and sometimes in lying position, whatever you desire. Main indication of this examination is dysphagia. Second barium meal examination, the patient is swallowing that, and barium, we allow the patient in different positions, supine, left lateral, right lateral, prone positions, even erect positions. And then there are two types totally single contrast. That is the contrast barium is producing a dense shadow, opaque shadow, because it does not allow the X-rays to pass through it, outlining the fundus and body of the stomach, pylorus of the stomach, and going to the various parts of the duodenum. First part, duodenal bulb, second part, third part, and fourth part, like that. And single contrast is better to outline the polyps and lesions, like that. But double contrast is better to outline the mucosa and peptic ulcer disease, in which we just give a small amount of barium, and mostly we give tablets or sort of that, which produces the gases. So gas distend the stomach and gas coats the barium well. Okay, so these are the few indications written here for dyspepsia, gastroesophageal reflux disease, hiatus hernia, partial obstruction, unexplained anemia, any suspected ulcer disease, any suspected masses, like that. For that, we do the barium meal examinations. Next one is a film that's showing you the barium follow-through examination. The barium has taken by the patient, and which has crossed the stomach, and then passing through the duodenum, and then going to the jejunal loops are located on the left side upper abdomen, and then iliac loops are located more lower down and right side, and then it continues into the cecum ascending colon. So this is a good picture image of the barium follow through examination. These are the indications for which we can do the barium follow through for the malabsorption, inflammatory bowel disease like Crohn's disease, and polyps, okay, any masses, and sometimes tuberculosis. Double
Doctor, excuse
contrast.
me.
Yes, please.
The picture
Yes.
was for the stomach was single or double contrast?
This is sort of a single contrast here. You see, mostly it's a barium is visualized. Huh? Okay.
And the
In this
previous
example, yes,
the previous I
single
see this.
contrast. This is single contrast. This is mostly it's a barium is visualized. Okay. In double contrast, like you see here in double contrast, the air is visualized in this colon. Some barium and some air. And on the left side image, you see here, it's a single contrast is shown to you. Okay, this is a single contrast examination, which is see outlining the rectum, pelvic colon, the descending colon, and the splenic flexure, transverse colon, hepatic flexure, ascending colon, cecum, reflux into the terminal ileum. See, this is totally outlining the large intestine with the barium single contrast examination, and SN is double contrast examination to distend the intestinal lobes and to barium coats the mucosa. So mucosal pathologies are best seen in the double contrast. So double contrast is more in practice. Okay, CT abdomen. Any question in the contrast studies? I hope some basic background knowledge you have acquired about the barium swallow, barium meal, barium follow through, or small intestine, and the barium enema examination. Okay, coming to the CT abdomen part, the CT scan of the abdomen is routinely done to identify the gastrointestinal tract, hepatobiliary system, that is the liver, gallbladder, pancreas, okay, spleen, the kidneys, urinary bladder, and the other relevant issues related to the mesentery, peritoneum, and so on. Okay, generally done without and with IV contrast medium and with oral contrast. Here, the barium usually we are not routinely in our practice using to outline the GI tract, but some water soluble contrast, which is less denser than the barium, is used. So patient is asked to drink that water containing the gastrographin or oral contrast agents. They start drinking 1 hour, half hour, or 2 hours before. Okay, and then at that time, after that, the technologists start doing the examination, CT scan. First, he will do without IV contrast injection, and then after that, they do again repeat the same exam after giving an IV intravenous contrast medium. The the oral contrast medium will outline the GI tract. The intravenous contrast medium will outline the vessels and the vasculature of the viscera. So IV contrast medium, after IV contrast medium is an ideal examination, okay? But both are done to compare if there's some underlying pathology, how much it shows enhancement based on that pathologies are better identified. So this is the protocol. Then there is a triphasic CT scan, some advanced form in which usually after giving contrast, the multiple times are done CT scan in the arterial phase, early arterial phase, late arterial phase, venous, portal venous phase, delayed phase, 5, 6 to 10 minutes, and so on. That's called triphasic CT scan. With okay, then visceras appear more homogeneous and better enhanced in the portal venous phase usually because the liver has 80% blood supply through the portal vein, so it will enhance better in that phase. Similarly, the spleen is better seen in the venous phase. Usually, transverse images, axial images are done, and then there's option of reconstruction the images in the sagittal and coronal planes. Any question on the basics of the CT scan in your mind, please ask me. Or is it clear to you? Boys, girls?
Clear.
Okay. Why I started with the urinary bladder? Okay. No problem. Focusing with the normal urinary bladder here, starting with the pelvic scans. Okay, in the pelvic region, what we can see, okay, the urinary bladder distended with the normal urine. Fluid appears low density. The computer has a system to check the densities. It's around 0 to 10 Hounsfield unit density. This is an axial plane image. These are the bowel loops, okay, colon, air in the colon, and then the mesentery, all these muscles, the bone, right pelvic region or hip region, and left side. And this is the sacrococcygeal region, back muscles, fat appear low density, darker. This is the sagittal plane image showing you the lumbar spine, sacrum, and this is enormously distended urinary bladder, almost occupying the pelvic region and coming into the lower abdomen as well as anterior aspect of the patient with the pelvic bone. This is the coronal image, enormously distended urinary bladder. Okay, the urinary bladder containing a focus of stones. So stones are almost accurately 99%, more than 95% diagnosed accurately with the CT scan, irrespective of their density, irrespective of their sizes. So a small stone at the right vesico-ureteric junction, small volume bladder with thick wall of the bladder with cystitis, sometimes with tumors as well as a mass, a polypoidal mass arising from the left side of the wall of the posterior wall of the urinary bladder. Commonest masses in the urinary bladder are transitional cell carcinomas. Then we have got option of the urography examination. Previously, we were doing intravenous urography, IVU or IVP, and now it's a CTU. CT urography means contrast injected through any IV vein, and when contrast along with the blood passes to the glomerular filtration and passing through the renal calyces and renal pelvis, and then outlining the, these are the renal calyces, renal pelvis, the right ureter going towards the bladder, and the same on the left side. Colors is an option in the system. You can give colors, you can blur the rest of the images. So this is called CT urography examination. Similarly, MR urography you can do with after injecting the IV contrast medium. The contrast is different in the MRI, which is gadolinium based. The contrast, IV contrast, is different in the CT system. So some patient who has got allergy with the contrast in CT can go for MRI because MR contrast is different. Okay, and the beauty of MR is that the fluid appear high signal even without contrast. Anywhere body in the body, fluid appear high signal in T2 weighted images. So even this MR urography can be seen without injecting the contrast. If the contrast is injected and excreted, then there's a good distension and good visualization of the urinary tract or any fluid containing structures. But otherwise, without injecting even, it can be seen and visualized. The purpose of doing the urography examination is to assess, is to investigate the hematuria, urinary tract obstruction, any lesions inside the urinary tract, like the transitional cell carcinoma can occur along the urinary tract. Then we have got the option of the angiography examination in CT as well as in MRI, just simply injecting the contrast through any IV vein and then tracking the bolus of contrast passing through any vessel. Like in this example, the contrast is outlining the aorta as well as the right renal artery and left renal artery. So assessment of the renal arteries anatomy is usually asked before the transplantation to check their anatomy, how much renal arteries are there. Okay, that would better. And then pathologically, the stricture or the stenosis in the artery is common to see in the old age due to atherosclerosis, or in the middle age females fibromuscular dysplasia relevant to the renovascular hypertension, and sometimes trauma and aneurysms could be seen. In the CT, we have got the option to give the color as well as in to blur the background other items and just to focus the arteries. Okay, so that's a possible. So this is called a, here it is shown to you the normal renal angiography, CT renal angiography examination. Then we have got an option, very good option of MRCP examination. M for magnetic, R for resonance, C for cholangiopancreatography. Okay, it's a non-invasive technique, and even you do not need to give the oral or IV contrast medium. As I mentioned you, in MRI, there is an inherent quality fluid anywhere in the body, like in this example, fluid in the duodenum, fluid in the gallbladder, cystic duct, intrahepatic ducts, common hepatic duct, common bile duct, pancreatic duct, are visualized as a high signal. We use the word signals, low signal, high signal in MRI. So the fluid has got inherent quality to be visualized on a one of the basic sequence called tituated sequence as a high signal even without injecting the contrast. So this is a wonderful investigation, can be done within few minutes, okay, without any injecting the contrast, outlining the biliary channels. This is a very good investigation to investigate the jaundice, particularly the obstructive jaundice, any calculus if it is present in the distal CBT, any stricture in the distal CBT, and so on. And it's free of radiation, so it's very safe in the youngs, in the even the females. It has got one disadvantage, a limitation compared to ERCP examination, in which the gastroenterologist pass the endoscope and reach the CBD, and they can do some intervention like remove these stones or dissect the strictures or pass the stent. That intervention is possible in ERCP, and that is beyond the diagnostic purposes. But MRCP remains a diagnostic test only. Is this clear up to this stage? This is this is an ERCP examination. This is the endoscope, which is passed, okay, by the gastro and GI consultant, okay, through the esophagus, stomach, duodenum, reaching to the second part of the duodenum, cannulating the papilla of water, and through that comes to pass the contrast into the CPD, which goes retrogradely to outline the common bile ducts and the pancreatic duct. So this is an ERCP examination. It has got radiation hazard because it's a radiation-based technique, but it has advantage that it can do interventions to remove the obstructions due to stone, due to stricture, and they can position the stent to bypass any obstruction. Is this clear to you? Are you with me?
Yes, Dr. Clear. Thank you.
Okay, ultrasound examination in the abdomen is a very good examination, radiation-free technique. It's a game of sound waves. Sound waves are passed, returned back, and then they are interpreted as echoes. Okay, the stones, they are visible as a echogenic structure. Okay, whitish structure with posterior shadows. Okay, and it's a good study for the solid organs, for the liver, for the pancreas, for the spleen, for the kidneys. Okay, even for the female genital organs. Okay, fluid is a friend of ultrasound. Fluids are easily seen in the ultrasound as distended bowel loops containing fluid, ascites, pleural effusion, pericardial effusion. They are best visualized by the ultrasound examination. And as an alternative to CT, appendicitis in the young children, non-obese patients, and pregnant patients can be evaluated by ultrasound. I have just mentioned few things here relevant to your course. There are a lot of things you will learn in the fourth year. This is a normal ultrasound examination. Okay, normal ultrasound examination outlining the cortex of the one of the kidney and the medulla. Cortex is a lower echogenicity, and inner medulla due to fat and vessels are more echogenic, more whitish. And in this example, we see the dilated renal calyces because of the distension of fluid, distension of urine, because this stone is obstructing that kidney. Stones are visible as echogenic structure with posterior acoustic shadowing. So this is a case of a stone with hydronephrosis of the kidney. The normal urinary bladder is outlined by the ultrasound examination, very easy. The fluid in the ultrasound examination appear as black. We call it anechoic. So if there is a fluid in the gallbladder, it will appear anechoic. If there's a fluid in the intestine, it will appear anechoic. If there is a ascites, pleural effusion, they will appear anechoic black. Okay. If there's a simple cyst anywhere in the liver, in the kidneys, in the thyroid, in the breast, in the pancreas, in the spleen, they will appear anechoic if it is a simple cyst. In this example, another example of the film is shown to you, a small volume urinary bladder with a large stone at the base. The stones appear echogenic with posterior acoustic shadows. Okay, now let's review what we have learned so far. Okay, this abdominal X-ray is shown to you. Okay, let's read first one. Okay, what do you think? What shadows are visualized? Are they small intestine or large intestine? Is it a normal or abnormal? So, anybody who want to comment on this film? That's taken in the supine position.
You can see
So,
the
what do you?
ascending colon,
Pardon again, please.
the ascending colon visible,
Mm-hmm.
and parts of small intestine centrally.
Mm-hmm. Mm-hmm. Okay, very good. So you are right. Part of colon is visualized on the right side. The small intestine loops are visualized in the central part of the abdomen, pelvis, stomach shadow is visualized. Diameter. What do you think? Diameter is more than 3 centimeter on subjective appearance, or is it a normal or abnormal?
Looks normal.
Mhm. If you
It appears less
compare,
than centimeter.
so it's a less than 3 centimeters, so it's a normal. So you can compare with this with the right side film. You see here, the right side film shows the enormously dilated central loops with complete folds, and at the periphery also you can see the transverse colon and descending colon, which are not too much dilated. So primarily, mostly it's a central loops dilated. So it's a case of small intestinal obstruction. Okay, gastroesophageal reflux disease. Reflux is a common phenomena, physiological phenomena. We all face this reflux in our, there is a system which rapidly clears the reflux. But if the reflux is persistent longer time, if the valve mechanism is not good, okay, so in some situations it can persist, and we call it a gastroesophageal reflux disease, GERD. Okay, majority of patients face heartburn. Okay, and often it's more aggravated by bending, straining, lying down, lot of coffee intake and so on. Okay, in lying positions. And dysphagia could be a problem related to strictures develop after a long gastroesophageal reflux disease, sometimes hoarseness of voice, atypical chest presentation, okay, and even the reflux may lead to recurrent chest infections because of the um, inhalation of the gastric contents, okay. And I have seen the cases with the coughing and asthma. Basically, they have got the GERD problem. Okay, there are complications related to the GERD. For me as a radiologist, this stricture is the most important for me. So a patient who has got initially developed his esophagitis and non-treated, and later on fibrosis in his stricture develops, so that can be initially better visualized by the barium swallow examination. The benign strictures are lower down, peptic strictures are lower down at lower esophagus, is smooth appearing with a long history of GERD. One important complication called Barrett's esophagus, in which there is a metaplasia of the esophagus, okay, the part of that esophagus which has already esophagitis and so on, due to the GERD. The bad thing, and significance of that Barrett esophagus is that it's a pre-malignant condition, can lead to columnar metaplasia and the adenocarcinoma development. Although Barrett's esophagus cannot be diagnosed by the barium swallow examination, and we need the endoscopy to see the changes, that metaplastic changes in the columnar epithelium. Okay, columnar metaplasia, to need that. And it is advised that such patients should be regularly kept in surveillance so that the cancer development can be excluded. Okay, so I have already described. You see, just I will highlight one point, that the how much it's significant clinically, that there's a 40 to 120 fold increased risk of developing the esophageal cancer in such patients. So Barrett's esophagus is a pre-malignant condition, and we have to follow that, okay, by the um, endoscopy. Peptic stricture, I have used the word, the literature is using the word peptic stricture. Okay. and to because of the long-term esophagitis and GERD. Okay, and we can start and outline that structure at the lower esophagus by barium, and ultimately all structure needs endoscopy and biopsy to rule out the malignancy. So primarily, I'm not concerned with the investigation of the GERD. That's a more medical concept you can read in the medicine. But my radiological part is to detect the peptic structure. Okay. Second condition in the abdomen is Crohn's disease. It's an inflammatory condition. It's said that it can occur from oral region up to the anus region, but is more common in the small intestine, and among the small intestine, more common in the terminal ileum. There are certain features, key features, I call it that, the which can differentiate the Crohn's disease from the ulcerative colitis. Both are inflammatory conditions. In Crohn's disease, there are deep ulcerations. In ulcerative colitis, there are superficial ulcerations. So, because of the deep ulcerations and the normal mucosa surrounding that, it may give a appearance like a cobalt stone appearance on the barium follow through or small bowel enema examination. Then, in the late stages, the pathology, as the pathology progresses, it may develop the strictures and fibrosis, which can be visualized in the barium follow through or small bowel enema examination. The key feature here, a characteristic feature here, is that these strictures of fibrosis or deep ulceration or pathologies in the Crohn's disease is not a continuous disease along the whole small intestine. There are skip lesions. There are multiple skip lesions. There could be multiple skip lesions. Means a area of ulceration, fibrosis, stricture, and then a normal area in between, and another area down uh, fibrotic stricture. Okay, so these are called skip lesions. Then in advanced stages, complication like development of the perianal fistula, which are better visualized by the MRI examination, or sometimes fistulous communication may occur between intestine loop to colon, or to intestinal loop to urinary bladder, and so on. So deep ulceration, stricture formation, skip lesions, fistulous communication are the characteristic features of the Crohn's disease. Previously, we were using, and still in some part of the world, the barium follow through examinations are used to make the diagnosis of these strictures and skip lesions or the fistulous communication. But nowadays, CT and MR high tech modalities are considered more sensitive, and they are routinely used for the diagnosis of the disease as well as for the findings of the complication as well as for the follow up of these cases, because it's a lifelong process. Although it is treatable, but even recurrences may occur. Okay, clear to everybody about the Crohn's disease? Trying to show you here in picture, and with especially endoscopy inside, you see the cobblestone formation related to the Crohn's disease, and that cobblestone formation is outlined by this oval circle, and it has related with the cobblestones in the ground. You see, because of that mucoid, the normal mucosa as well as ulcerated and inflamed and polypoidal formation, they lead to this cobblestoning in the terminal ileum, which is a peculiar feature of the Crohn's disease. The terminal ileum is most commonly affected, so there's a stricture development. The barium follow-through examination indicated by this white arrow. This is one of the signs. Although TB can occur here and can produce the strictures like that, but we have to correlate with the clinical situation as well as the blood findings. The second important inflammatory situation in the intestine is ulcerative colitis. Ulcerative colitis, as the word ulceration is developing, and it's affecting primarily the colons, although it can affect the small intestine, but to a lesser extent. So primarily, it's a large intestine disease. Remember that it almost always starts in the rectum, and then the disease ascends to involve the sigmoid colon and then descending colon, or may involve the transverse colon or the ascending colon. It's a continuous disease. It's not a skip lesion like in the Crohn's disease, rectum must be involved first and then continuously ascend the disease to involve the descending colon, sigmoid colon and descending colon. There are superficial ulcers rather than the deep ulcers we saw in the Crohn's disease. And there are marked development of the pseudo polyps, okay? And in the advanced stage, even on barium, they show a lead pipe appearance, meaning the hostrations patterns disappear, they become colon become more smooth and give an appearance of a lead pipe appearance of the colon. And one of the complication related is the development of the toxic megacolon, which can be easily diagnosed by the abdominal X-ray and must be done whenever you are planning for barium enema examination. Simple abdominal X-ray should be done to rule out is there any toxic megacolon. If it is, which is diagnosed by enormous dilatation of the colonic diameter, more than 9 centimeter transverse colon, for example, and it's a contraindication to do the barium enema examination. These are the two films, okay? The film which is shown to you here on the left side are showing you the whole of the colon shows superficial ulcerations. And here the double contrast barium is showing you the loss of frustrations you see here in the descending colon and part of the transverse colon. They call it lead pipe appearance. See on the right side colon, good hostration patterns. So this is advanced stage of the ulcerative colitis. In this picture, showing you the differentiation between the Crohn's and ulcerative colitis. One first location. See the location of the Crohn's disease. It's more in the small intestine. It can affect the large intestine, but peculiarly you can note that there are skip lesions affected, normal, then affected. So there are multiple skip lesions, particularly in the small intestine and the terminal ileum. While the Crohn's is a continuous disease, continuous inflammatory disease, starting in the rectum and ascending to the sigmoid colon, descending colon, transverse colon, like that. Okay, the same is written here. The important thing is that the ulcerative colitis has got the marked increase in the chances of the malignancy. Okay, that's an important thing. Risk of cancer is more in the ulcerative colitis compared to Crohn's disease, a slight increase. The peculiar feature, lead pipe appearance of the colon in ulcerative colitis, okay, and it's a continuous disease and superficial ulcers are formed. And there are skip lesions in the Crohn's disease and the fistulous formation are common to see in the Crohn's disease. Any question in inflammatory bowel disease? Any question? Things are clear to you? If
Yes.
you have any difficulty, you can ask me, please. Okay,
Just
so
you
I will.
mentioned
Yes, please.
you mentioned that megacolon is contraindicated for enema, barium enema.
Yes. Mhm.
Actually, we have taken a disease in pediatrics called Hirschsprung disease,
Mhm.
and we can use barium enema despite the infant or child has megacolon.
Hirschsprung's disease is a disease of children. Okay.
Yeah,
In Hirschsprung's disease, there are a ganglionic segment in the rectum or rectosigmoid junction and beyond that. So as a result, that part is narrow and beyond proximal part are dilated. Okay, and usually the infants they present um, after birth, usually in few weeks, in few days, unable to pass the meconium, or later on may present as a constipation problem in older children. So barium is the first line investigation to outline that narrowing of the rectum. Okay, the normal ratio of the rectum to colon is 2:1, means 2 times larger diameter of the rectum compared to the colon. In the Hirschsprung, it reverses 1:2, means rectum is appears narrow on barium and the colon is dilated, and there is a transition zone, and it's the diagnosis is confirmed by the biopsy only to check the egg ganglionic segment. We learned right now, we discuss ulcerative colitis, which is an inflammatory bowel disease affecting the colon, okay, rectum and colon, and common to see in the adult, not in the young children, infants like that. Okay, and again, we can do the barium enema examination to outline superficial ulcerations, the continuous disease, the loss of aspirations, lead pipe appearance, and so on. Only one contraindication was the complication related to that. Sometimes they develop such patient toxic megacolon, means toxically dilated, enormously dilated colon. Okay, and if we take an abdominal X-ray and we found any toxic megacolon, enormously dilated colon, they are risk to introduce further barium and air because there's chances of rupture. So that's why it's said that it's a contraindication to do the barium enema only in that complication cases. I hope this is clear to you.
Yes, clear. Thank you.
Welcome. Okay, diverticular disease, usually a silent disease in the old age psychiatric patients or patients who are constipation problem like that. They have more pressures inside the lumen, so their mucosa, submucosa, they can herniate through the wall. That's condition is called diverticulosis. Okay, significantly affects the although can affect any part, but commonly affects the sigmoid colon, pelvic colon. Okay, and low fiber diet is considered as one of the risk factor for this development of this condition. And it is usually incidentally diagnosed by barium enema examination done for some other reasons. Okay, and we found multiple diverticuli in the colon. Okay, they are smooth rounded projections filled by the barium. Okay, and one of the complication of diverticular disease is the diverticulitis, means maybe one of the diverticulum may got inflamed. That situation is called diverticulitis. That diverticulitis inflammation may lead to rupture of that diverticular wall, abscess formation, fistulous communication, rupture, hemorrhage. So a diverticulitis and its complications cannot be diagnosed by the barium enema. It is best diagnosed by the CT scan. But diverticular disease, diverticuli are the best diagnosed by the barium enema examination. So this picture is representing you these herniations of the diverticuli, and one few of the diverticuli shown here is leading to inflammation and diverticulitis, which can subsequently develop abscess formation, fistulous communication, hemorrhage, and so on. Okay, so the left side is showing you the double contrast barium enema examination. Outline, air is outlining most of the colonic segment, and the outpouching sac-like structures from the wall, mostly containing barium. These are the multiple diverticuli. Openings of the diverticuli from inside of the lumen can be seen through endoscopy or even virtual endoscopy by the CT scan. Things are clear to you? Colonic polyps. Polyps are common situations in the large intestine. Okay, they are the benign masses of the mucosa protruding into the lumen. Remember reverse of diverticulum. Diverticulum is outside pouching, and they are protruding inside the lumen. So majority of the polyps are benign adenomas. Sometimes they are inflammatory adenomas. Okay, so barium enema will outline a single contrast barium enema will outline the polyps. Polyps are soft tissue structures, so they will be outlined as a filling defect. Okay, defects we will see in the image. Okay, and CT colonography can accurately diagnose the polyps, as well as colonoscopy helps to take the biopsy. Okay, Multiple polyps may be found. There are various syndromes written in the book. Just I will mention one or two. Familial adenomatous polyposis is a disease which is an autosomal dominant inherited disease with multiple polyps, innumerable polyps involving the colon, runs in the family, usually evident in the second decade of life. And there's a risk of development of malignancy in such polyps almost 100%. 100%. It means that two things are very important in familial adenomatous polyposis. Number one, if anybody is diagnosed in a family to have a colon adenomatous polyposis, first of all, colonectomy should be done to avoid the development of stage of malignancy. Second, all the family members should be screened and regularly screened because it runs in the families. Okay, and there's a 100% risk of developing the malignancy. Second situation is the Peutz-Jeghers syndrome. Also, there are polyps development, but this has no malignant potential. This image is a colonoscope image, better seen than the right side image, which is a virtual colonoscopy, not actual colonoscopy, also called CT colonography. This is a software, like if you remember, even you are playing, or as a children, our children are playing the video games. They are flying their aeroplanes and their cars through the tunnels. They pass through the tunnels, like it's all software. So similarly, we can fly through and see through the lumen of the colon, to the lumen of the intestine, through the lumen of the bronchus, without actually passing the scope. Okay, so that's called virtual colonoscopy or CT colonography examination. Almost comparable results are seen. That polyp, which is better visualized in the colonoscopy, actual colonoscopy, which is invasive procedure, by a virtual colonoscopy. Only advantage of the actual colonoscopy is that you can take the biopsy. In virtual colonoscopy, you cannot take the biopsy, so it's purely diagnostic. Polyps are protrusions, benign adenomas inside the lumen. Colonic carcinoma, adenocarcinoma, most common GI malignancy. There are dietary factors like low fiber intake, increased refined carbohydrate intake, increased fatty intake. They are risk factors for the development of the colonic carcinoma. Okay, and usually develops incidentally and detected at the advanced stage. Patient may have got only symptom of the altered bowel habit or like that. Okay, more common to see almost half of the cases seen in the rectum, and the almost 25% in the rectosigmoid junction or sigmoid colon, and rest in the remaining colon. Barium enema is a good alternative examination, although the endoscopy remains the investigation of choice because of the advantage of directly visualizing the cancer as well as taking the biopsy. But the good alternative is a barium enema examination, which may demonstrate or colonic cancer. That colonic cancer may be a simple thickening of the wall, like an inflammatory situation, or maybe a polypoidal mass, maybe a stricture. Okay, so usually when a stricture is there, luminal layering is there, the appearance on the barium minimum examination, they have given this name, a sign, apple core sign or apple core deformity, means center of the apple has been eaten, like that. Okay, or sometimes a polypoidal mass may be seen, like you see here. This is a colon. Okay, the this localized structure is produced. So when we see the lumen of that structured colon, and this wall, these walls, surrounding walls have the cancer, so it looks like an apple core appearance or apple core deformity, which is a very characteristic sign for the colonic cancer. Coming to the hepatobiliary system, there's a good role of ultrasound. The X-rays has got a very less role except detecting the stones, which is rare to see, visualizing the abnormal layer in the biliary system. Okay, so practically X-rays has got not a good role. Ultrasound is the first line to screen to detect any lesions in the liver. We can see the cyst in the liver, we can see the masses in the liver, we can see the hepatitis in the liver, we can see the metastasis in the liver. Okay, we can see the fatty changes in the liver. Okay, and ultrasound is very good to differentiate between a cystic lesion and a solid lesion, because the cysts are usually almost always benign. A solid lesion may be a benign, may be a malignant lesion. If solid lesions are visualized, which has got features suggesting malignancy, okay, then we need the use of a CT-IV contrast triple phase study, and that narrows down our differential diagnosis. The commonest benign lesions we saw in the liver are the cyst and the hemangiomas. Okay, and these both can be easily diagnosed and differentiated by the ultrasound and CT scan compared to the malignant lesions. Hepatocellular carcinoma, that's a liver cancer, can be diagnosed in the portal venous phase, and biopsy is needed for confirmation of that. Okay, MRI has got a very good role after the CT, or as an alternative when CT scan is contraindicated. For example, there's a contrast allergy, or some features are of hemangioma better diagnosed by the MRI examination. So MR has a good role. Early detection of small cancers in the cirrhotic patients is diagnosed. So MR is more superior than CT in the detection of the tumors in the liver. Interventional radiology, regarding that, some interventions may be done, okay, by the interventional radiologists to drain the abscess, to give chemoembolization to the bleeding arteries, okay, or even they do tips for the portal venous hypertension and so on. And there's a popular now radio frequency ablation, that is thermal destruction of some of the tumors to reduce the mass of the tumor. So detection and characterization of the liver mass we can do with the starting with the ultrasound examination, followed by the CT and MRI examination. Remember, ultrasound remains the first line investigation in the liver and biliary system. Commonly encountered masses, as I mentioned, cyst hemangiomas, sometimes focal nodular hyperplasia, adenoma, common to see in the females taking the hormonal, taking the birth controlling pills for a long time. Malignant diseases like metastasis, carcinoma, cholangiocarcinoma. So they all can be encountered initially by ultrasound, and further assessment of the solid masses is done by the triple phase study, either by CT or by MRI examination. The carcinoma, cancer of the liver, shows rapid enhancement in the arterial phase, because this is something unique. The cancer is taking its blood supply mostly from hepatic artery, while the liver is taking its most blood supply, 80% blood supply, from the portal vein. So liver enhances best in the portal vein, and the cancer enhances best in the arterial phase. So this is one of the feature which can give a clue for the diagnosis of the liver cancers. And there are other characteristic features like hemangiomas have a characteristic enhancement pattern that's called a centripetal enhancement pattern. Okay, you will learn more details in the rest. Similarly, most of the metastases are hypovascular, less vascular, so they become less conspicuous when the liver is enhancing in the portal venous phase. It means that 80% of the metastases are best diagnosed in the portal venous phase. You will learn more details in the fourth year. Okay, simple diagnosis of the hepatic cyst by the ultrasound examination. As I told you, fluid appears anechoic, jet black. So well-defined anechoic with post-aqueous can happen. Good sign, confident diagnosis of simple hepatic cyst. Similarly, hepatic cysts are non-enhancing, so liver is enhancing in the portal venous phase. So well-defined thin wall fluid-containing cyst in the liver on CT scan. Hemangioma, as I told you, it's a centripetal enhancement. Centripetal enhancement pattern means that it starts enhancing. This is a non-contrast CT. It starts enhancing in a nodular fashion at the periphery, in the arterial phase, and more enhances towards center in the portal venous phase, and then after 10 minutes delayed phase almost completely fill in of the contrast. So this enhancement pattern is starting from periphery to center is called centripetal. That's a characteristic enhancement pattern in hemangioma. If seen, even no need of doing the biopsy, confirms the diagnosis of hepatic hemangiomas. As I mentioned you, the liver cancer enhances as the cancer takes most of the blood supply from the hepatic artery. So it enhances best in the arterial phase when the liver is not good enhancing. Liver best enhances in the portal venous phase because 80% blood supply coming from portal vein. So at that time, cancer is having washout of the contrast. So easy diagnosis, but we need confirmation by the biopsy. As I mentioned before, that 80% of the metastases are hypovascular, so they are not enhancing or less enhancing, okay, compared to the normal parenchyma enhancement of the liver in the portal venous phase. The cirrhosis of the liver is a clinico-pathological diagnosis. Radiology is usually asked to detect any development of the hepatocellular carcinoma. But in this example, we can see just shrinking of the liver and irregularity of the wall of the liver, which is a sign of cirrhotic patient, as well as the adjacent ascites. Compare this liver with the smooth border of the liver, normal liver. Gallstones is a situation in which the multiple stones are detected. Patient remains silent most of the time, may be detected due to the gastric upsets, heartburn, sometimes small stones passing through the biliary tract causing obstruction and obstructive jaundice and surgical emergency. The ultrasound examination remains the investigation of choice for the detection of the gallstones. They appear as echogenic foci mobile within the gallbladder. Okay, the gallbladder containing the bile appears as an aneroid. Sometimes gallbladder is distended, okay, because of the obstruction. If there's a right upper quadrant pen, always we think of the stones in acute cholecystitis, and investigation usually starts with the ultrasound examination. Okay, so if the ultrasound examination mostly outlines the stones or the acute cholecystitis, okay, if not, then we can take the help of the CT scan. Okay, CT scan may outline the complications related to acute cholecystitis like gangrenous perforation, emphysematous cholecystitis, empyema, and so on. And in pregnancy, we can have alternately use of the MRI examination. That's an ultrasound examination which is showing you the thickening of the wall of the thickening of the wall of the gallbladder, distension of the gallbladder, pericholecystic fluid. Okay, similar things can be seen on the CT scan, thick wall of the gallbladder, pericholecystic fluid around the gallbladder. So these are the signs of the acute cholecystitis. Although acute cholecystitis is a clinical diagnosis, but radiology helps the confirms the diagnosis. Investigation of the jaundice, particularly an obstructive jaundice. Investigation starts with the ultrasound to to differentiate that there are dilated biliary channels or not. If you see the dilated biliary channels in the ultrasound, that suggests the diagnosis going more in favor of a obstructive jaundice. And if the biliary passages are not dilated, that goes in favor of a medical or non-surgical jaundice. Obstructive or surgical jaundice could be due to a stone obstructing in the CBD, resulting in CBD dilatation, even pancreatic dilatation, okay? Or sometimes a mass in the pancreatic head or mass in the duodenum periampullary region can cause obstruction. Really, a stricture in the distal CVT even can cause the surgical jaundice. So once we visualize that there is a biliary dilatation, the second step investigation should be done MRCP, magnetic resonance pancreatography. Okay, it's a very easy investigation and it can outline the biliary channels, dilated biliary channels, any stricture obstruction, any stone in the distal CBD. Okay, and if needs the removal of the stone, cutting of the stricture, or passing a stent as an intervention management, so ERCP is indicated for that purposes. Alternatively are the PTC. I will not discuss at this stage. CT scan is only called when we are suspecting something outside which is obstructing, for example, a pancreatic mass or a duodenal mass which is obstructing the distal CVT. Okay, this is an ultrasound examination showing you a acute cholecystitis within the gallbladder, a dilated CBD. CBD can be measured and routinely we measure on the ultrasound examination. Normally, it's less than 5 centimeter. Okay, and if it is dilated, okay, due to stone in this example, okay, and stones are also visualized in the gallstones. So next good investigation is to do the MRCP examination. Here it is a normal MRCP examination to outline you the pancreatic duct biliary channels, and the example of another MRCP examination showing you the dilated CBD and some filling defects due to the stones in the distal CBD. So MRCP after ultrasound is a good investigation to outline the biliary passages and the cause of the biliary obstruction.
Doctor,
And
where are the stones?
ERCP, pardon?
Where was the stones? Previous one.
Yes, there were stones. You see, normal, the right side image is showing you a normal CBT and pancreatic duct, not dilated, and this is dilated CBT, and these filling defects are due to stones, multiple stones. This is the duodenum. Okay, these are dilated intrahepatic ducts. And in the next image, the ERCP, okay, a procedure of ERCP examination on the right side is shown, dilated CBD. And here, a very good outline of the hugely dilated CBD with multiple filling defects. These filling defects are due to stones. Although the clot, although the air can produce the filling defects, okay, but the we know the cause here in this case is the multiple stones here. Okay, moreover, air will collect superiorly in the semi-rectoric position. The stones will be more in the dependent position, and this is the endoscope. The beauty of added advantage of this examination is they can through Dormia basket. They just put basket catch. This is the Dormia basket. They just open after going inside, catch the stone and remove it. Okay, so that's a very good procedure of the ERCP examinations. Okay, let's review some what we have learned in this CT scan image after IV contrast medium showing you a large liver and there are multiple less enhancing lesions. So what do you think? What diagnosis you want to give? Is it a cyst?
Hepatocellular
Are they
carcinoma.
metastasis? Is it a hepatocellular carcinoma? Is it a hemangioma? So what is your impression?
Hepatocellular carcinoma.
Hepatocellular carcinoma. What about other opinions? Any other opinion? Anybody, please?
Metastasis?
Metastasis. Okay. Anybody else want to give any opinion? We will learn from there how we are making the diagnosis. Anybody else? Okay, now we have got two choices, hepatocellular carcinoma and metastasis. Number one, hepatocellular carcinoma can be multiple, but usually single. Metastasis can be single, but usually multiple. So first criteria, whenever you saw multiple lesions in the liver, so we have preference of the metastasis. Second, it's a portal venous phase, portal vein is outlined. The liver is more enhancing compared to these lesions. So lesions are less enhancing. As we have learned, 80% of the metastases are hypovasculars or they are less enhancing compared to normal parenchyma enhancement in the portal venous phase. So these are metastasis, correct diagnosis. Okay, what is this examination? Is it ERCP or MRCP?
MRCP.
MRCP.
MRCP, correct. Because we are not seeing endoscope. I remember endoscope when I was a student, like a snake, huh? Okay, a snake-like appearance. Okay, I remember like a snake-like appearance, eye of the snake. See here? See the eye of the snake? I feel like a snake. So I am not seeing that snake here. I usually, when I was a student, I was creating a lot of mnemonics and some associations so that I can remember and recall myself. So that's a good formula. Anyhow, is it a normal MRCP or abnormal MRCP?
There is obstruction by a
There is
stone.
obstruction. This arrow is very good. This arrow is indicating a filling the fact. So there is a stone, most likely a stone in the distal CBD, which is causing dilatation of the CBD, common hepatic duct, the intrahepatic ducts as well as. I'm thinking this could be these are the stones in the CBD or could be the part of duodenum. I'm not sure. Always be honest in your description in the exam. Whatever you saw, say it to the examiner. Don't hesitate. Okay. Liver. CT scan, triple phase contrast study of a liver. Female patient, asymptomatic. Non-contrast CT, arterial phase, portal venous phase, delayed phase. There's a characteristic
Angioma.
enhancement of the lesion. Yes, very good. Hemangioma diagnosis. Centripetal enhancement is peculiar with the hemangioma diagnosis. Even if you saw this pattern of enhancement, no need of doing the biopsy even. What is this examination? So you will not forget the snake, huh?
RCP.
ERCP examination. Normal, abnormal?
Abnormal.
Abnormal. Enormously dilated CPT with multiple filling defects due to the stones. Okay, CT, A image in the arterial phase and B image in the portal venous phase or delayed phase. So a lesion which is enhancing in the arterial phase and washout in the delayed phase or portal phase,
Carcinoma.
most likely carcinoma, because the cancer is taking its arterial supply from hepatic artery, so it enhances in the arterial phase. Okay, we have got time. Yes, we have got still 20 minutes. We can go. Urinary calculi. Urinary calculi. Okay. Are these topics are relevant to your this what you call it? We call it the
Cluster.
block system. You have got the block system. We call it block system. What you call it? This
Cluster.
cluster. So are these topics are relevant to your clusters?
Yes.
Fine. Okay. Urinary calculi. Stone in the urinary system. I use the word urinary system to denote stone or calculus in the kidney, in the ureter, in the bladder. So I use the word urinary calculi, okay? Most calculi or stone form in the kidney and then pass down into the ureter or bladder. It's self-formation of the stone in the ureter I have not seen in my life usually. But yes, there are some situations in which a stone itself can form in the bladder because there is a already predisposed diverticulum or infectious focus, which can later on lead to stone formation. But again, mostly it has passed from the kidney. Males are slightly more exposed for the formation of these stones compared to female. Usually peak age is younger age when doing more sports activities, athletic activities, more dehydrating themselves, okay? But stones can be seen at any age. I have seen in the even in the children's, okay? 70% of the stones are calcium containing stones, okay? and 15 to 20% are the triple phosphate struvite stone, sometimes called staghorn stone. Means the appearance is a larger stone with branching pattern like the horns of the stag. Lesser amount are of the uric acid, which are poorly radiopaque, means poorly visualized on the X-ray because they do not contain the calcium. And 1 to 2% are cysteine, they are not visualized on the X-rays. So you can say 70-80% stones, 85% stones can be diagnosed by the X-rays, but there are various factors. Suppose intestinal loops are more dilated, air fecal gas shadows are overlying over the kidney shadows or ureter shadows. Okay, so there are variable factors, but compared to the gallstones, you can say the gallstones may be maximum up to 30% diagnosed by X-ray if these situations are good, if the X-ray is good technically, and the urinary calculi can be diagnosed 70-80% by the X-rays. They present with the pain, dull pain, sometimes silent hematuria. Okay, there are certain physiological strictures where more likely chances stones can be obstructed at the uretropelvic junction. Okay, the crossing of the ureter through the iliac arteries, or the juxtaposition of the vas deferens or broad ligament. Okay, or where it enters into the urinary bladder wall. We always start our investigation when you are suspecting a urinary stone, a ureteric pain, a renal pain. Okay, thinking of the stone, always start wise to investigate with the stones. One of the disadvantage of the ultrasound examination is that the small stones, particularly less than 3 millimeter, are very easily missed, not detected, because there are some already echogenicities in the center part of the kidney on ultrasound examination due to fat content and due to blood vessels inside. Okay, the as the stones are larger and larger, more than 5 millimeters, 610, they are easily picked by having the echogenic focus with the posterior acoustic shadows. I will show you the picture. Although ultrasound is less accurate than CT, okay, because of the limitations of the ultrasound. Fat is an enemy of the ultrasound. So if patient is obese, the sound waves are difficult to pass through the fat, and we can not see the underlying kidneys in a well contrasted situation. Okay, so the fat, fecal, bowel gas shadows, they all are not good for the ultrasound sound waves to transmit. Okay, and second thing, most of the ureteric stones are not visualized. Ureters are very thin tube-like structures and deeply located along the transverse process. So usually they are not visualized. But if the proximal ureter or a distal ureter near to the urinary bladder have got a stone, can be visualized because of their dilatation. Remember that the multi-detector CT or CT scan is a more accurate, more sensitive investigation to detect the urinary calculi, irrespective of the size, irrespective of the density, irrespective of the chemical composition, irrespective of the location, either in the kidney, in the urinary bladder, in the ureter. Okay, as well as they can detect the hydroureter and hydronephrosis, dilatation of the ureter and hydronephrosis. And now technologies are there, even they take the densities and try to uh, give impression of the chemical composition of these stones just based on the detection of densities, which are helpful for the management purposes. Another added advantage of the CT scan, that it just gives a low dose without IV contrast medium to detect the stones. So a low dose CT KUB examination is considered most accurate, most sensitive investigation for detection of the urinary calculi. X-ray nowadays, a good policy of X-ray is that once the stone is already diagnosed, then we can have follow-up of that X-rays, whether the stone is increasing in size or having migration lower down or not, because of the low X-ray radiation dose compared to the CT scan. Things are clear to you? If you have any question related to urinary calculi, role of ultrasound, CT, X-ray, please ask me. No question. Okay, the X-ray is showing you here. Multiple X-rays are shown in different patients. You can see a staghorn type, a large stone conforming the branching of the calyces and renal pelvis. Such a called staghorn. This is the shadow of the right kidney and left kidney and the staghorn calculus. Our left kidney have got a stone at the left renal pelvis, and this image X-ray is showing you a stent has been passed through the left kidney, left ureter, and the lower end, lower tip is in the urinary bladder. Double J stent or pigtail catheter to relieve the obstruction. Ultrasound examination showing you a hydronephrotic kidney with a stone appearing as a echogenic focus with post-acoustic shadowing, and this is the hydronephrosis. This is the cortex of the kidney and upper pole and lower pole of the kidney. This is the urinary bladder containing urine anechoic and the dilated distal CBD because of this obstructing stone which is appearing as echogenic focus with posterior acoustic shadow. CT scan axial image showing you a tiny stone in the within the renal pelvis, hydroureter, as well as stone in the renal pelvis, left side. Or left side dead shape stone in the left mid-ureter with proximal hydroureter and hydronephrosis and thinning of the cortex of the kidney. That was the CTKUB without the injection of contrast. So what we have learned so far, gastroesophageal reflux disease. I'm making a summary of all these we have learned so far. Gastroesophageal reflux disease is a clinical diagnosis. Endoscopy, although, is the priority examination for the to see the changes, particularly the Barrett's esophagus development and development of the cancer. However, barium solo is indicated whenever patient complains of dysphagia to locate the structure of peptic structure, or sometimes a malignancy development, a malignant structure can be defined by the barium solo examination. Barium meal is a good alternative examination for the diagnosis of the peptic ulcer disease, although endoscopy remains the standard care investigation because of the option of direct visualization of an ulcer or a gastric cancer or taking the biopsy. Relevant to the liver, okay, ultrasound remains the first line investigation, okay, followed by the triple phase CT or MR for characterization of a solid mass detected in the liver. The abscesses, they can be easily diagnosed by the ultrasound examination as a fluid collection and may be needed if biopsy is needed. The cyst can be easily diagnosed and differentiated by the ultrasound examination, and any solid lesion by virtue of the contrast enhancement pattern as we noticed for the diagnosis of hemangioma, metastasis, liver cancer, we can have diagnosis by the CT scan examination. Okay, that's already we have discussed in detail about that. Or regarding the biliary system ultrasound, most sensitive investigation for the detection of gallstones, okay, although x-rays are less, 10%, okay, some mention about 10, 20%, 30%, okay. Uh, Practically, x-rays are not used for the diagnosis of gallstones. Almost all of the investigation for any biliary colic starts with ultrasound examination. So it not only diagnoses the stones, but also presence of any cholecystitis. But if complications are suspected, then we need the contrast enhanced CT scan. And if the biliary system appears dilated by ultrasound, the next step to do the MRCP examination to detect the dilated biliary system, as well as can detect the cause like the stones or stricture. And want to do some intervention management, then ERCP examination will remain the investigation of choice. Okay, let's do some practice of the questions. Which of the following investigation is indicated for the diagnosis of esophageal stricture?
Barium
Option A,
swallow.
abdominal X-ray; B, ultrasound; C, barium swallow; D, endoscopy. So one boy's opinion, barium swallow. What about the girls? Your opinion?
Same.
Barium swallow. Good answer. Okay. Another question, a barium follow-through examination showed deep ulcerations, there are escape lesions and strictures in the small intestine. Which one of the following is most likely diagnosis?
Crohn's.
Is it a Crohn's? Is it ulcerative colitis? Is it diverticulosis? Is it intussusception in children?
Crohn's disease.
Crohn's disease option. Okay. Boys' side, from your side, what is your first diagnosis?
Yes, the same.
Is the same because there are deep lesions, deep ulceration, skip lesions, strictures in the small intestine, which are characteristic findings for the Crohn's disease. Next question, contrast enhanced CT abdomen shows a hepatic mass which is hypodense on non-contrast CT, and after IV contrast shows typical peripheral nodular enhancement or arterial phase, and further fill in of the contrast in the portal phase, and delayed phase is complete fill in. So it's a centripetal enhancement pattern. So which one of the following is most likely diagnosis? An adenoma,
Angioma.
carcinoma, hemangioma, cyst. Yes,
Angioma.
hemangioma. Okay, girl side, from your side.
Same.
Yes, because this typical pattern enhancement is hemangioma, centripetal enhancement, and even if you see that, you may avoid the biopsy. Next question, a 38 years old woman presented with pain and tenderness in the right hypochondrium. Which one is indicated for the suspected acute cholecystitis? Which one of the following investigation is indicated for the suspected acute cholecystitis? So from which investigation you will
Ultrasound.
start? Pardon?
Ultrasound. A.
Ultrasound. Girl side, your answer?
Same.
Good. Okay, which one of the following investigation is most sensitive for the diagnosis of suspected urinary calculi?
CT.
Boy side.
What did you mean by sensitive?
That can detect easier, better.
I did not connect it with you. Again, can you repeat your answer?
C.
Yes, CTKOB is the most sensitive. X-ray will detect almost 70%. Ultrasound has limitation of obesity, distended bowel loops, small size, okay? And it's more operator dependent. If the person who is doing is competent, they may give a better diagnosis, otherwise not. But CT gives accurate morphology irrespective of the size, location, density, content, without even IV contrast medium, it can detect. So CT remains CTKUB, a low dose CT remains a investigation of choice for the diagnosis of urinary calculi. So this finishes your lecture. Thank you very much. I appreciate your presence, your participation, active participation. Do you have any question? Do you
Yes,
have any
doctor.
question?
Something maybe just a little unrelated, but what is the difference between the gall polyps and gallstone on the imaging?
What is the difference between gallstone and a polyp? This is your question?
Yes.
You see, gallstones is a stone formation in the gallbladder. Polyp is usually a benign adenomatous lesions arising from the mucosa protruding into the lumen of the gallbladder. So, question how we make difference. First, how they present. Polyps usually are asymptomatic. Stones can be asymptomatic, can present with the biliary colics. Okay. On ultrasound examination, the stones are detected as an echogenic focus, lazim with posterior acoustic shadowing. And usually they are mobile. When we turn the position, stones change the position. Polyps appear as a soft tissue density structure along the wall, fixed to the wall of the gallbladder. Okay, they can be single, can be multiple. Small polyps we ignore. We just make a follow-up. There's a criteria of the size that usually the polyp which are larger than 10 millimeter have more chances of changing into malignancy. So if the size is suppose 5-6 millimeter like that, we just keep following with ultrasound examination, nothing to do. But if the size is rapidly increasing or a larger size around 10 millimeter, then usually the surgeons, they remove the gallbladder and then they do the biopsy for confirmation whether malignancy has occurred or not. So this is the basic difference. I hope you got the answer of these questions.
Yes, thank you.
Welcome. Any other question by any student?
Thank you very much, Doctor.
Okay, good luck to you. Please take your attendance and give it to your course organizer. I request both sides, boys side as well as the girls side.